Tonight we are very lucky to have Dr. Jay Shankar. He's going to be talking to us about the treatment of acute ischemic stroke, and I will let him be the master of all of that. I am your moderator tonight, so I'm going to be letting people in. I want to remind everybody to keep their sound muted, so the little microphone on the bottom, if you can just click mute for that, would be great. And if you have any questions or comments, we're going to ask you to use the chat box on the bottom of your screen. It looks like the little paragraph and it says chat. You just click on that and you type in. So as you can see, I'm going to do this for you. As I'm doing 3 things at once, my computer flips around. Anyways, you can just type in your questions on the chat box and it'll pop up. And between myself and Dr. Shankar, we can answer your questions at the end of the presentation. So we have another couple minutes. There's a few more people coming in. We just hope everybody's getting settled in and we will get going shortly. And once we get going, Dr. Shankar, I'm going to mute myself. So you'll be the only one with mic and we will, I'll join back in at the end of your presentation. So without further ado, I will continue to let everybody in, and that's great that you're all coming. We will start our Fit Talk for this evening with Dr. Jay Shankar, and again, it's on the treatment of acute ischemic stroke. So I will mute myself and pass it over to you.
Perfect. Can everybody hear me? Good evening, everybody. I think this is a wonderful time. Hope everybody had their supper, and we will just have some information, hopefully some entertaining information. I'm Dr. Jay Shankar. I'm one of the interventional neuroradiologists at the Health Sciences Center. And today I'm going to talk about treatment of acute ischemic stroke. I must thank Reh-Fit for the invitation, Ria, Sue, and I think Christine from Heart and Stroke Foundation introduced me to Reh-Fit. So thank you all for this opportunity. And thank you all who have logged in for your time to talk about this. So let's begin as a customary. These are my disclosures. None of these have anything to do with what I'm going to talk about today, but I'm supposed to put the slides in all my talks. So here it is for your information. Today we are going to talk about what is stroke, and predominantly we'll talk about acute ischemic stroke and different treatment options, timeline for treatment options, and how the evidence in medicine supports this treatment. And we'll learn about all of this with one of our patients' journey in Manitoba. Okay, so stroke definition. Tell me, did you think we're going to talk about the breast stroke? Maybe not. How about this one? I don't think so. How about this one, the gall stroke? I don't think so. We're going to likely talk somewhere like this, where half of the body is missing. That's the common concept we get when we talk about stroke. So World Health Organization defines this like this. A stroke is caused by interruption of blood supply to the brain. And that can happen 2 ways. Either the blood vessel bursts, and that we call hemorrhagic stroke, or the blood vessel is blocked, and that's when we call it ischemic stroke. And we are going to talk about ischemic stroke for next 20 minutes or so. So how do you know somebody has stroke? Well, stroke, remember, stroke happens when the blood supply to the brain is blocked. So it all depends upon which part of the brain had their blood supply blocked. You all know that different part of the brain is responsible for different type of functions that our body can perform. So depending upon which part of the brain is affected by the blocked blood supply, the stroke could present with different symptoms. However, most commonly, we know that it's the sudden onset of weakness or numbness of the face, arm, legs, often on one side of the body. That's classically what we understand with stroke. However, it can present with different other symptoms as I've listed over here, depending upon which part of the body is affected or which part of the brain is affected by the blocked blood supply. Okay, so let's look at how things are being done in our own province. And we will see this with one of our patients. So let's start the journey of acute stroke care in Manitoba. Here is Miss VL. Some of you may know this person. I'll show you her face. She has given permission to share her story and share her video with everybody for educational purpose. But look at this. I'll just still keep her Mrs. VL. She's 89-year-old, living independently at home, shoveling her snow. This is last November, getting ready for festive season. She's 89 years old and she has 20 grandchildren and great grandchildren. And her favorite pastime is around the festive season is to make pajamas for her grandchildren. She lives in Verdun. You all know where Verdun is. This is what she has been preparing for all the pajamas, is getting ready for her grandchildren and great grandchildren. And she is on anticoagulant. At this age, most people have some kind of anticoagulation going on. She was admitted in the local hospital with GI bleeding. And for that, since she presented with bleeding, her anticoagulation was stopped. And 2 days later, in the hospital at 1 a.m., in the middle of the night, she developed left-sided weakness and slurred speech. Remember, that's the stroke. Remember, this is the classic presentation of stroke: one-sided weakness and slurred speech. This is how we look at it. You have seen this FAST logo on the side of our ambulances. FAST stands for face drooping, arm weakness, speech difficulty. And if you notice any of these three, it's time to call 911. And this is very, very important. Time is of essence in stroke. More the time you save, more of the person you save. Why is that so? Because time is brain. What does that mean? That means we lose, after the stroke onset, we lose 2 million brain cells every minute. And you can imagine, I'm pretty sure nobody has extra brain cells to lose. And that's why when there is stroke, we rush the patient to the hospital as soon as possible. Remember our lovely lady? She is already in the hospital. She is in Verdun, but the Verdun doesn't have the CT scanner. So she is being transferred now to the nearest primary stroke center, that is in Brandon. And this is a 50 minutes drive, and by 4:30, remember the onset of symptoms was at 1 a.m. and by 4:30, she got her CT scan of head and CT angiogram, which shows that there is no bleed in the brain, which is good news. But there's something missing here. You see the blood vessel is occluded right here on the right side of her brain, and that is causing the symptoms on the left side of her body. So this is the problem now. So what do we do? And this is how we learn. 89 years old, somebody can say, hey, why bother? She is 89 years old. We all have difficulty. A stroke is a devastating condition. Maybe that's it. We don't have to treat her. But that's not how we look at it. Definitely not. Why is that so? Because when we know this, so if 10 patients get stroke, if you don't treat patients, then what happens is roughly 1/3 of these patients get only 1/3 of these patients get some kind of good outcome, and 52% or half of them become disabled. And this is the problem. It's not that and only one in five could potentially die. And what is also known is, for if to take care of this half of the population with stroke, it costs us $107,000 or $100,000 per year. If we can move these patients with a disability to the one who can live independently, then that costs only $48,000 per year. So this means if we can treat one patient to make them independent, one patient with stroke and make them independent, the healthcare system saves $60,000 per patient. And I don't think any other treatment could potentially save this much of healthcare dollar to the system. And so this is very, very important. And we know that of course, it's good for the patient, good for the healthcare system. And we always try to treat unless the family decides against the treatment. So what is the standard of treatment in patients with acute ischemic stroke? Have you heard about this Drano? Yes, we do have a Drano for the brain, and this is called TPA. Okay, this is the clot busting drug which we administer intravenously in the vein, and that can be given up to 4.5 hours from the time of onset of stroke. Okay, so remember, Our Lady had stroke at 1 a.m. By 4 a.m., we know that she has stroke and one of the blood vessel is occluded. So 3.5 hours in, is she eligible for this clot busting drug? The answer is yes. Hey, did you forget? She was admitted in the hospital with the bleeding, GI bleeding. So if somebody is bleeding, we don't want to give them more clot busting drug to make her bleed more. So the problem is, this clot busting drug is not indicated in her case, okay, because she has bleeding. So what are the other options? Let's look for it. So this is the other option called endovascular thrombectomy. The way we do it, and this is only done here at the Health Sciences Center. I'm one of the 4 people who do this, and this is we go through the blood vessel in the upper part of the leg, and we puncture the artery and put a long tube called catheter that goes up into the chest. We bypass the heart and go inside the neck into this blood vessel, and then through this bigger tube, we put a tiny tube called microcatheter, and then we go inside the brain and go see into the clot. You can see the clot here, and we put a tiny wire that goes across the clot, and then we advance this tiny tube called microcatheter that goes across the clot, and then we backload a fishnet. You can see here, this is called stent, and this we deploy across the clot and then wait for 4 to 5 minutes. In this 4 to 5 minutes, the brain gets fresh blood. That's good news. And also the stent gets incorporated into the clot, and then we pull the clot out. Okay, and what we see is we get the clot out of the brain. This is called endovascular thrombectomy, and in short, it's called EVT. Okay, so why do EVT? Remember this graph I showed you? If on medical management, only 1/3 of patients with acute ischemic stroke can get good outcome. But if we add EVT or endovascular thrombectomy, roughly half of these patients become independent at 90 days from the treatment, and less patients will become dependent or disabled. And this is the beauty of this treatment. Number needed to treat is only 2.5. What does number needed to treat means? It means simply how many patients we need to treat to get one good outcome. So imagine 2.5. The lower the number needed to treat, higher the effectiveness of the treatment. So it's a very, very effective treatment. So how long you can use it for? It can be used up to 6 hours from the onset of symptoms. So remember, we have already lost 3.5 hours and the patient is still in Brandon, and this treatment can only be given in Winnipeg in the Health Sciences Center. So journey continues. Remember, 1 a.m. Verdun, onset of symptoms in Verdun, 4:30 a.m. In Brandon, we found out all that the patient has a stroke. They called us. In next half an hour, we decided, yes, the patient should be transferred to Winnipeg. And 5 a.m., the patient left Brandon. We expect the patient to be here before 7 a.m. So that would have given us 6 hours from the onset of symptoms. But we all know that's not how things work. What happened here is patient reached here at 8:30 a.m. Now what? It's already more than 6 hours from the onset of symptoms. What do? We brought the patient from Verdun to Brandon to Winnipeg. Should we say, oh, sorry, too late? No, not really, because in 2018, the new studies came, which showed that actually this endovascular thrombectomy can be effective up to 24 hours from the onset of symptoms. But between 6 to 24 hours, it is effective in select few patients. And how do we select patients? Patients are selected based on these like advanced imaging called perfusion images. So perfusion imaging was done in Our Lady, and you can show that this is a large part of the brain which is at risk of dying, that shows in the red color, but the underlying brain is not dead yet. So it means there is a lot of brain that is at risk of dying, but because of her system, the brain that at risk brain is not dead yet. So we have a lot to salvage. And this is what we need to show to make the patient eligible for the endovascular thrombectomy if they are presenting after 6 hours of onset of symptoms. So Our Lady did qualify for this, and we took the patient at 10:30 to our angio suite. And you see, remember that this is the artery which was occluded right here. We took the patient. This is the microcatheter that goes from the groin all the way up into the brain, across the clot, and the stent is placed from here to here. These are tiny markers. I don't know if you can see this. And we pull the clot out. What happens? The artery is open. Remember this here occlusion? An artery is open, and this is the lady next day. Give me a smile. Big. Can you say cheese? Remember, she could not speak well, and she has weakness on the left side. That's how she presented. So look at her now. Cheese. Can you puff your cheek? Awesome. Can you close your eyes? Awesome. Good job. Can you put your hands out there? Both of them at the same time. Okay, awesome. In front. Put your hands in front, like this. Yep. Yeah, awesome. Good job. Go ahead, do that. Hands on the side. Okay, and in the front. And awesome. So she was ready to be discharged home in next 2 days, and she went home. This is the kind of recovery some of these patients make after this treatment. So how common this problem is? Every 10 minutes in Canada, someone suffers a stroke. And worst is over 14,000 Canadians die from stroke each year, and more than 50,000 Canadian experiences stroke-related symptoms, and more than 300,000 live with the ongoing effects. So that is the bigger problem. Well, This is not true. This is a joke. Okay, so what are the risks of stroke? In the next 10 years, we expect the incidence of stroke to increase further because of our growing elderly population and rising prevalence of diabetes and obesity. Cost to Canadian economy is $3 billion, and it's going to balloon further over next 20 years. Okay. Stroke, one stroke, many faces. It doesn't recognize age, race, ethnicity, and even kids have stroke. The youngest patient we had 4 or 5 months back was 5 years old. Okay, so that's where stroke is. It's very important to remember time is of essence when we have stroke around us. Rush and really rush the patient to the hospital and try not to bring the patient on your own. Call 911. Our ambulance people are very well trained to know what to do, which hospital to take to. Our general feeling is, oh, go to the nearest hospital. Not really true in stroke case, because we have dedicated hospital across the province that are very well suited for stroke treatment. And then they know when to transfer patients to the health sciences center, which patient is eligible. We had the discussion. So do not take patients yourself to the nearest hospital, because the nearest hospital may not be the best hospital for that patient. Very important to remember, but rush, call 911 as soon as possible. So if you can remember this, that 2 million neurons, 2 million brain cells die per minute after the onset of stroke. And remember, nobody has spare brain cells to let die. Okay, endovascular treatment is very effective, and it's a new standard of care and can be done up to 6 hours from the onset of symptoms. But in select few patients, it can be done up to 24 hours from the onset of symptoms. And that's it. Well, before you ask me questions, I'm going to ask you questions. Get ready. Are you guys ready? Perfect. Okay, think about this. How many brain cells die after the onset of symptoms per minute? We have to remember this. And I'll let you respond whichever way you can. And the answer is, I think 2 million brain cells die every minute after the onset of symptoms. How about this? What is the time window for endovascular thrombectomy? It means how long after the onset of symptoms endovascular thrombectomy can be done to reverse the symptoms of stroke. Up to 6 hours in all patients, but in select few patients, it could be up to 24 hours. And it's very important to remember this treatment is available only at the Health Sciences Center in Winnipeg, and we transport patients from all across the province, as well as from adjacent province, Northwest Ontario and Eastern Saskatchewan. So when a patient is eligible for treatment, what is the standard treatment? Standard treatment is when the patient is eligible, they should get the clot busting drug and should get transferred to our hospital for endovascular thrombectomy. And that's it.
Those are great questions. Thank you, Dr. Shankar. That was a great presentation. It rang true. I have a family member that had a stroke, so I can kind of relive the process now. And it was really great to put all the medical information with a story behind someone who had to travel from Verdun, right, and go through. I think we can relate to those stories, and we can really understand the importance of getting someone to the hospital quickly and safely using the ambulance. So those are all really good things. Does anybody have any questions that they'd like to ask our presenter tonight? You can use the chat box if you like. If you're not comfortable using the chat box, that's fine. You can unmute yourself and ask the question. We'll just try and do one at a time. So the chat box is a little easier. If there isn't any questions right away, maybe we could ask Dr. Shankar if he's got another scenario. Typically, if someone's in Winnipeg and presents those symptoms and say they're already maybe in hospital in HSC, I'm assuming that process can happen within an hour sometimes because we don't have the transportation limitations, or is there ever any complications with that?
Yeah, if the patient is, that's a good question. If suppose our lady happened to be in our hospital itself, like at the Health Sciences Center, the process works really fast. Like we have time parameters to follow. Like the patient, once they come to the hospital, within 15 minutes they get CT scan, and then within another hour from the scan, they come to our angio suite for endovascular thrombectomy. And usually within half an hour from the time patient comes in our OR, they get their blood vessel open. That's called revascularization.
Right.
And those are the time points we try to achieve. Can we achieve all the time? Not really, but most of the time we are able to achieve those time points.
Right. A couple of the same comments. They're asking about STARS. So when is the STARS transportation system used? Is it more of a rural area or?
Yeah, more of the rural area, and we don't get to choose which means of transport is used for the patient. It's decided based on the location of the patient, based also on the time of onset of symptoms and how far after we find the patient. All of that comes into play, and usually the EHS personnel communicate with the emergency room doctor here at the Health Sciences Center, and then the communication decides which means to use to transport the patient to our hospital.
Mm-hmm. In terms of preventing stroke, one of our viewers had a question just asking kind of from a prevention perspective that like diet and exercise for the heart connect and the brain, obviously that's where stroke occurs. Does that play a significant role? I would say yes, but maybe you can add to that.
Oh, definitely. Any sort of healthy living exercise is very useful for stroke. Someone can say that, hey, then what about the little kid I mentioned that he was only 5 years old? How come he had stroke? And those are unfortunate situations because some people have more vulnerable blood vessels that tear easily, and in those cases sometimes we get these younger people get what we call as dissection or tear to their blood vessel, and once there is a tear to the blood vessel, clot forms at the location of tear, and that goes into the brain and cause stroke. So those are unfortunate situations. I don't think we can do much to prevent that to happen, but majority of stroke happens after 50 or 60 years of age. And like anything you can do to make yourself healthy, eat healthy, do exercise, take care of yourself. If you have any underlying condition, take medication, watch out your blood pressure, lipid, all of that's going to help prevent stroke.
Good, thank you. Don't have any other questions just yet. I'll give everybody a couple more minutes as all the information tends to percolate. Is there certain surgeries that are higher risk for stroke after them? Maybe you can.
Not necessarily.
General?
That's a difficult question because any surgery can potentially cause slow flow of slow blood circulation because the patient is not moving too much immediately after surgery. So the answer is yes, but it happens only when there is some underlying predisposing condition, and that becomes more obvious post surgery. So yes, after surgery, we do see stroke happening after surgery. And other more common risk factor is, like if the patient happened to be on some kind of blood thinner, either antiplatelet medication or anticoagulation, and they had to stop for the surgery. And remember, now the blood needed to be thinner, and they had to stop the blood thinner because they had to undergo surgery, and the two condition together could predispose the patient to more stroke. That can happen.
Okay.
I see a question here. I assume that taking an 81 milligram aspirin post cardiac patient is a risk factor for stroke. No, actually, it reduces the chances of stroke, actually, because remember, 81 milligram aspirin is given to you to keep your blood thin. So anything that is good to prevent heart attack is also good to prevent stroke. So the two pathology, two disease has a very similar pathway, affecting two different organ of the body. One affects the brain and one affects the heart. So stroke is also called brain attack, just to have the same kind of feeling about heart attack. The only difference is heart attack is painful and patients know it right away. Whereas brain attack or stroke is not painful most of the time, and many people don't even recognize the symptoms. So important thing is recognition. Recognize the symptoms as early as possible. Call 911 right away as soon as you recognize the symptoms, and bring patient should come to our hospital as fast as possible.
Could I ask a question, please?
Go ahead.
Okay. I was just wondering what factors are taken into consideration to allow a person to have the surgery up to 24 hours?
That's a good question. So, as I mentioned, the one thing that we really need is the time of onset. Okay, so if the time of onset is beyond 6 hours, if it's under 6 hours, you don't have to worry. All patients will be considered to undergo endovascular thrombectomy, provided there is a large vessel occlusion. What that means is one of the blood vessel which supplies the brain is occluded, and it's pretty big vessel. We know that the clot busting drug may not work very well in those blood vessels, so we tend to use endovascular thrombectomy for those patients. If the patient presents beyond 6 hours, the one and only thing that we consider in those patients is to confirm that there is salvageable brain. What that means is there is a volume of the brain which is at risk of dying if we don't do anything. Then only we go after those patients. If it's too late, some patients may have the brain already dead by that time. In the part of the brain which is at risk of dying may be dead by that time. In that, there's no point going after those patients, no point doing endovascular thrombectomy, because we may not help the patient and unnecessarily put the patient at risk of the additional procedure.
Okay, and you could tell if the brain is dead through a scan or x-rays or?
Yeah, that scan that I showed you, that can show us, it's called perfusion imaging. And that it takes only a couple minutes to do that. It's a type of CT scan. And we do this for all of our stroke patients. And we see that shows us whether the brain is dead or not dead yet, or is it at risk of dying or not. So those questions need to be answered before we go after, before we do the endovascular thrombectomy in these patients.
Okay, so no part of the brain must be dead to be able to do it.
That's not completely true. Because it's all time dependent, correct? So if after the stroke onset, roughly 2 million brain cells die every minute. But some of us are lucky to have arrangement in the brain that blood can get to that part of the brain through different route, and those are called collaterals. So there is collateral blood supply to that part of the brain, and if it is so, then their brain could survive for longer. And there may still be small part of the brain that may be dead by the time they get the scan done. But if a larger part of the brain is at risk but not dead yet, that means it's still salvageable. We go ahead and treat those patients. And
Oh,
that's a complex decision-making process, but we do make that decision with the discussion with the patient family, and the stroke neurologist.
well, I'm glad to hear that even if there's a little bit, that you still may be able to do the surgery. Okay, thank you very much.
Yes.
Dr. Shankar, there's a couple questions still. So someone asks if you think you're having a mini stroke. Maybe you can speak to that. Is there anything a doctor can do? And they related to their scenario that they presented a mini stroke before they had, I guess, what they consider a bigger stroke. I don't want to put it in terms of size. And they weren't able to find anything. Can you comment on those?
Yeah, so that's a good question. And most of my talk was about major stroke, where we definitely see the weakness and disability. Anybody can detect it. In people who have mini stroke, and mini stroke simply means that you experience symptoms, but most of the symptoms disappear on its own by the time you get to the hospital, or before you even get to the hospital. Those are called mini stroke. Many times mini stroke could be a sign that a bigger stroke could come afterwards, but not necessarily. And mini stroke simply means the clot was too tiny to be seen on our scan, but it has occluded a tiny blood vessel in the brain. And the clot may dissolve on its own from the mechanism of our own body, or if you're taking some kind of blood thinner, that may start working as well, and clot eventually dissolves. Or the other option is, remember I talked about the collaterals, that some of our brain may have alternate route of blood supply. So if it is so, then also the stroke will improve, stroke sign will improve. The question is, if you improve completely, then you don't need any treatment. Remember, we only treat if you have symptoms. So for mini stroke, if you come to our hospital and by the time you reach here, everything is all right, all we do is to give you medication to prevent further stroke, because you don't need any treatment for that stroke. So all we need is to prevent further stroke.
A couple questions here. Someone's wondering, if you miss a dose of your aspirin, how long does it take for a blood clot, I guess, to form?
Yeah, and that's a good question. It also depends upon how long you have been taking aspirin for, right? So we roughly, these are all rough estimate. We feel that you have to be on aspirin for at least 7 days for the aspirin to be effective. Okay? So now, if you started aspirin 2 days back and missed it today, well, likely your aspirin hasn't kicked in yet. So the blood can clot. If the blood has a tendency to clot more, then it's possible that it can clot. But if you're taking aspirin for a year or 2 years and you miss one dose, usually it's not a big deal. You just go ahead and get the dose when you remember and carry on. It doesn't, if you miss one dose, it doesn't put you at risk of stroke for sure.
So there's a question about alcohol and, I guess, increasing your risk for stroke.
It's a complicated question, because alcohol doesn't directly increase the risk of stroke, but alcohol is associated with other issues of high cholesterol and other blood problem, and that can together increase the risk of stroke for sure.
Okay, and we'll do one more question. What's the difference between epilepsy and stroke?
Two different conditions altogether. Stroke is, as I mentioned, it's a weakness of hands, legs, visual problem or speech problem. Just to explain this, or in coordination, epilepsy is involuntary movement like this of one part of the body or the other part of the body. It could be only localized to face, finger, anywhere, but that's an abnormal movement of the body part, not weakness of that body part. It has been shown that certain people who are experiencing epilepsy may have weakness immediately following epilepsy or seizures, and that is called Todd's palsy. And that simply means that patient has seizure, and after seizure, that part of the brain goes into hibernation and doesn't work for some time, but that recovers completely. That kind of palsy is not associated with blood clot in the brain.
Okay. Great, thanks. Those were great questions, everybody, and you answered them all really well, Dr. Shankar. So again, someone's just saying thank you. I'll echo that, Jan. As always, we really appreciate all the presenters that we've had and continue to have. So thanks again. We do have another presentation next Tuesday with Dr. Olga Taliva about living with SCAD, which is spontaneous coronary artery dissection. So that'll be a really interesting presentation. You probably are colleagues with her, maybe have dealt with her. So we're looking forward to that talk. I wanted to say thank you again for everybody for joining us on this very cold evening and taking time to join in on our Fit Talks. And hopefully everybody has a really nice evening and a really nice long weekend. And stay warm and stay safe, everyone. Thank you again.
Thank you, and stay warm. Thank you all.
Yeah.
Bye-bye.
Okay. Bye.
Bye-bye. Thank you.
Thanks.